Hello, folks. Today we're going to be talking about, for the next few minutes, the 2025 changes and how that's going to be affecting the RHCs and FQHCs out there in the area of care management. This is really big. This is something that's very exciting. I can't tell you how excited, honestly, I am about 2025 on so many fronts, so many ways. I haven't been this excited over an incoming new year for quite a while. Okay. But one of the things y'all need to understand is I've been doing this a long time, almost 40 years. I think March will be my 40th anniversary in consulting with doctors all over the country, in seminars and consulting, writing books, et cetera. But and to say that this is probably one of the most exciting times that I've had in the areas of reimbursement is saying a lot. Starting on January 1st, there's some new rules regarding the GO 511. And some of these changes that's taking place in the area of care management should easily be able to put an additional $340,000 to $515,000 a year net income into the bank accounts of rural health clinics and FQHCs. You say, well, what's that based on? That's based on basically 200 Medicare patients, because I was trying to be super conservative on these numbers I'm going to be going over with you today. So when we're talking about care management on this right here, we're talking about the new opportunities. And when you say, well, what exactly is care management? Care management includes everything from remote patient monitoring to personal care management, chronic care management, self-measuring of blood pressure, BHI care management, chronic care management, the new ACPM codes that we're going to be talking about in just a moment. All of these codes I'm showing you here on the screen is calculated into the reimbursement this year and for the first half of next year for GO 511. And say, okay, what exactly is GO 511? GO 511 is a kind of a catch-all code that they were planning on getting rid of January 1st, but CMS decided to delay that until until July of next year. So for the first 6 months of next year, you're still going to be able to use GO 511 in your clinics, okay? And the neat thing about this code is you can build the same code, the GO 511, if you're doing chronic care management, and you can build GO 511 if you're doing OPM for the OPM, et cetera. You say, well, what do you mean by that? You can build out multiple units of GO 511. Like in this email right here that came in from the RHC payment team, as well as the identical email came back to us when I questioned the FQHC folks at CMS. It said only the codes listed below can be billed as general care management services using that code GO 511. You can bill this code multiple times in a calendar month. However, each CPT code listed can only be billed for the Rhc code GO 511 once per calendar month for a single patient if all the requirements are met. And as it says here in red, for example, an RHC could bill remote patient monitoring services using Rhc code GO 511 four times in a calendar month, once for each CPT code listed. You say, well, what do you mean by that? Let's break it down. RPM has, well, really there's 5 codes now for RPM, but let's say 4 right here that's showing on this email. 99453 is for setting up a patient on the remote patient monitoring, teaching the patient how to do their blood pressure or glucose test at home. Although you maybe teaching them over the phone or teaching them in person in the office, either one. Setting that patient up into the system, into the computer system. So every time they do a blood pressure or glucose test, the data goes into their portal for their name. Okay. 99454 is for doing at least 16 days of testing and you providing the equipment to the patient, 16 days out of 30 days. So that code does require 16 days, and that's 99454. So if you're billing it out under GO 511, you'd bill one GO 511 for the 99453, another for the 54, another for the 57. 99457 is for 20 minutes of your staff spent time in monitoring talking to the patient, having an interactive communication, advising the physician or nurse practitioner or PA what the patient's numbers were, telling the patient how to do the testing or how to change out the batteries in it, or answering questions they have, or even just calling them to remind them to test. 99091 is a code that's typically used by Medicaids, but that's also for 30 minutes of time spent by the physician staff. Well, starting January 1st, they're also going to be covering the RPM 99458 also. Keep in mind, this email I'm showing you right here was from 7 months ago. This came out in March of this year. No, I'm sorry. Yeah, March of this year, whenever I got this email from them. You say, well, how is this so exciting? Why has this got you so excited? Okay, can just imagine right here on the GO511, all you can do. Now, one of the different changes that they're having is, as of January 1st, you can bill that out either as a GO511 or individually for these codes, 99453-58, or the 9943739, or the 99490 for chronic care management, or the new advanced care planning codes. You can bill in addition to the GO511. You say, okay, so from January 1st through June of 30th, we can bill out either way. But as of July 1st of next year, they're going to the period of whenever you can only bill it out under the individual codes, because they're getting rid of GO511. So the first 6 months of next year is a transition period. Now, again, July 1st and later next year, you have to build each code inadvertently, because right now they're planning on deleting the GO511. Now, we don't know that for certain yet, but this is what the November 1st Federal Register came out and said they plan on doing. And we will have a final notification from CMS on this on December 9th, when the Federal Register comes out with the final rules, because they've given us kind of a pre-look at it, an advanced look at it. So you sit there and say, okay, well, what about this APCM that you're talking about? What is that? APCM is the Advanced Practice Care Management, Advanced Primary Care Management. And currently, GO511 includes chronic care management, principal care management, chronic pain management, general behavioral health, remote physiologic monitoring, remote therapeutic monitoring, which is totally different than RPM, community health integration, and principal illness navigation, as well as that new principal illness navigation peer support. What it does not include is going to be the 3 codes that we're going to be having starting January 1st for the APCM. You say, well, what exactly is the APCM? APCM is the Advanced Primary Care Management, giving you an opportunity. You can either do the typical chronic care management you've been able to do for years, or starting January 1st, you can do the new APCMs. And you say, well, which one's easier? Which one's going to be more profitable? Well, the GO556 is going to be mainly for the probably 70% of your Medicare patients. Those are the Medicare patients that have one disease, one chronic disease. GO557 are for those that have 2 or more chronic diseases, and GO558 are going to be those that's part of the Medicare, Medicaid program out there that we're going to go into in just a moment. Now, one of the changes also January 1st is where this year you cannot bill directly for vaccines and vaccine administration, because that's part of the PPS rate or the all-inclusive rate. Starting January 1st, you'll be able to bill out hepatitis B vaccines and their administration separately. You won't be having to bill it out as bundled into the AIR or the PPS rate. And that's one of the changes that I think is exciting. Starting January 1st, again, we can bill add-on codes for care management additional time. What does that mean? Well, 99458 is for each additional 20 minutes of remote patient monitoring, where this year, RHCs and FQHCs only get paid for the basic codes, 99453, 5457. And then if your doc is spending the 30 minutes time, instead of the 57, you bill out to 99091, but you bill them out as a GO511. Starting January 1st, you get to bill out the additional times the same way fee-for-service clinics do. For instance, fee-for-service clinics can bill out up to 3 charges for 99458 if you've gotten 3 additional 20-minute time frames. And by the way, that code is called a mid-level code or a midpoint code. Not mid-level, but a midpoint code. So you say, okay, kind of break this out for me right here when we're talking about the care coordination and adding in these other codes and payment rates, et cetera. Okay, let's take a look at it. For January through June of next year, you can build it out either the GO 511 or the fee-for-service codes individually, okay, independent codes. My advice is go ahead and build it out under the GO 511 for the first 6 months of next year, because the reimbursement for that is $77.10. I'm sorry, $72.98. Where if you look at these other codes independently under the physician fee schedule, you're looking at the average in the country of being 49, 50, 40, 40, et cetera. So it makes a lot more sense to bill out 3 or 4 units of GO 511. In fact, it's a lot more profitable because if we're billing it out under the GO 511, you're looking at a net profit per patient per month of somewhere between $141 to $214 per patient net profit. So if you just have 200 Medicare patients getting OPM from you, and that's not very many, then that's an additional $340,000 based on $141, or $515,000 based on the $214. So for the first 6 months, you really definitely want to be using the GO 511 code rather than the independent codes that you have over here. Starting July 1st, we'll have to go to the independent code, but still, even then, the RPM is still going to remain very profitable for you. The first half of the year, you're looking at these kind of profits. The second half of the year, you're looking at typically $103 to about $143. We say, well, why $143? Well, if you have 2 99458s, you're looking at, again, about $180 there minus the $70, whatever. So you're coming out with about $103 net profit, which isn't bad. That's about $247,000 a year. This is what fee-for-service clinics are getting right now. I mean, we'll be getting January 1st, but this is what rural health clinics will be getting after July 1st of next year. Again, that's that 6-month transition period. Remember, CMS classifies RPM in the same category as they do chronic care management, remote therapy monitoring, and some other services, BHI and others, as care management. And as such, they allow companies or doctors' offices or clinics to be able to use an outside company to come in and do the service. And that would be called what's called pass-through billing. You're allowed to do pass-through billing on those services as long as it's not a fee for percentage or a fee splitting. In other words, what do you mean by that? You can't, and I know companies out there that's advertising, hey, doc, we'll come in with our CCM or we'll come in with our RPM, and you just pay us 60% or 65% of what you get. My my attorneys that I've dealt with for the last 40 years, I'll say the same thing. Stay away from that because that's a stark violation. But Don, their letter, they show me the letter from their attorney saying it's legal. Their attorney's job is to protect their client, not you. That's why you can't really trust those letters that's coming from the attorney saying those things are illegal, because they're not looking out for your best interests. You'll be the one that'll be fined, not the RPM company. That's why because I own an RPM company, and there's no way in the world I do a percentage basis. You can't do that right there. You get in trouble. As it says right here, we're also finalizing a policy to continue the adoption of definition immediate availability as including real-time audio and visual interactive telecommunications for the direct supervision of services, all the way through the end of next year. You said, what does that mean? That means that right now, if your doctor is at the golf course or your nurse practitioner sitting at home or getting their nails done or whatever, they're not in the office, as long as they've got their smartphone with them and you can reach them if need be for an audio video communication like a Zoom or whatever, you're using, FaceTime, whatever you're using that's HIPAA compliant, to have your staff and that doctor or the nurse practitioner talking to them, then that meets the guidelines under direct supervision for this year. And next year, they will also, for rural health clinics if we're talking about the different kind of services, like you'll continue to bill for RHC and FQH services furnished using telecommunication technology all the way through the end of next year. You say, well, isn't that the same as it is for fee-for-service clinics? No, fee-for-service clinics don't have that option for next year. Fee-for-service clinics can only do that right there with certain types of patients next year, and then only if the patient's at their home. So it also came across and said in the Federal Register, we're finalizing our policy to continue to delay the in-person requirement for mental health services furnished via communication technology. In other words, if you want to continue to be able to give their patients home health information, or if you want to continue to give them telemedicine and the patients at home, and you're in an RHC or FQHC, you get to do it next year all the way through until January 1st of 2026. You say, well, what's going to happen then? Who knows? I mean, with Donald Trump taking over right now and assigning RFK over the HHS and this, I'm sorry, Dr. Oz, whatever you call him, I don't know his first name, but Oz, who knows what the future holds right now? And with Congress changing and taking a much more strong effect on trying to continue to provide telemedicine, I got a feeling that they're going to be doing away with that and saying, okay, you can continue to do telemedicine after this because it's proven to be effective. Overall, folks, I have doctors all the time tell me, hey, I'm too busy to be able to do chronic care management, or I'm too busy to be able to do RPM. That's the nice thing about these being classified as care management. You don't have to do anything. Like, for instance, in my RPM company that I own, we do everything for the client, whether or not we're talking rural health clinic, a FQHC, or we're talking a fee-for-service clinic. We have clients all over the country, including a large clinic over in Hawaii with 7 locations, and I forgot, like 20-something providers. We do all the work so their staff doesn't have to. And most companies doing CCM or RPM will. You don't have to just use me, although obviously I'd like for you to do that. But you can use whoever and let them do it for you. Now, you cannot do pass-through billing for ultrasounds or somebody bringing in like a neuropathy testing machine, or somebody coming in doing lab in your office. You can't bill those and then pay that company to do that pass-through billing for those companies. They're not be classified as care management, but you can do that in RHCs, FQHCs, and fee-for-service clinics for RPM, CCM, et cetera. And this is exciting because I know that you guys are desperate for increased income. Y'all been suffering for years in the clinics because you've been trying to figure out how can we keep our doors open with all the increased cost we have. Well, it's time to start working smarter. You don't have to be working hard in order to do this. You can work smarter and get that $500,000 additional income. Well, if you have 400 Medicare patients in your clinic, $1 million additional income. It's not that difficult. And especially if you're willing to listen and learn from this right here. So if you want more information, you can go to donself.com. That's my website. Click at the top where it says schedule and grab a 15 to 30 minute time with me and ask me questions about RPM, ask me questions about CCM. Let me go through that with you and show you and give you some options. And I think you're going to be very surprised. Again, if you need to reach out to me, you're more than willing to, more than able to call me at 877-DON-SELF. That's 366-7353. Email me at donself@donself.com, or again, go to my website, grab a time on my schedule, and let's talk. I think this can help you. Well, I try to keep it down to 20 minutes, and what do you know? I'm right at 20 minutes. Y'all have a blessed day. Email me with any questions you have about this, and I will try to help you in any way I can. Thank you again. And again, I hope y'all have a blessed week. And remember, this is good news. So let's make sure that you're excited about it.